Erectile dysfunction is defined as the consistent or recurrent inability to attain or maintain a penile erection sufficient for satisfactory sexual performance. Estimates suggest it affects up to 30 million men in the United States. In the mid-20th century, research by Masters and Johnson characterized sexual response as a sequence of states: desire, arousal, orgasm, and resolution. They categorized erectile failure specifically as an impairment of the arousal phase. Modern urology has moved the focus from these early psychological definitions toward the biological mechanics of the entire vascular system. This change in clinical approach treats localized failure as an initial indicator of systemic vascular health. The primary driver behind this link is endothelial dysfunction. When the inner lining of the blood vessels is damaged, it restricts blood flow throughout the body long before symptoms appear in larger organs. Penile arteries are significantly narrower than the coronary arteries feeding the heart. Because of this size difference, systemic arterial plaque will obstruct these smaller pelvic vessels years before they are large enough to block the heart's blood supply. On average, symptoms of erectile dysfunction manifest and precede major cardiovascular events, like a heart attack, by up to 5 years. In younger men, this hemodynamic failure correlates with a 50-fold risk increase of future cardiac events. To treat the condition effectively, clinicians must look past the localized symptom and evaluate the entire cardiovascular system, starting with the baseline physiological mechanism. A healthy erection requires the synchronization of the brain, nerves, hormones, and blood vessels. The process begins with a neurological impulse originating in the brain and spinal cord. This signaling pathway relies on a hormonal baseline of testosterone, which is required to maintain the health of the neural pathways. These signals travel through the nervous system until they reach specialized structures in the pelvis. The nerve signals trigger a rapid influx of arterial blood into 2 cylinder-shaped structures called the corpora cavernosa. As blood fills this sponge-like tissue, the cylinders expand to create rigidity. Getting blood into the penis is only the first step. To maintain the erection, the body must trap the blood using the veno-occlusive mechanism. The expanding cylinders physically press against the outer veins, pinching them shut so the blood cannot escape back into systemic circulation. This creates a hydraulic lock. A failure at any single point in this chain, whether a damaged nerve, a blocked artery, or a leaky vein, will prevent the system from functioning. Broadly, the system fails in one of 4 ways: vascular blockage, neurologic damage, endocrine failure, or psychogenic interference. The American Urological Association diagnostic protocol begins with a comprehensive medical and psychosocial history to isolate risk factors like smoking or diabetes. Clinicians then use validated questionnaires, like the Sexual Health Inventory for Men, to standardize and measure the severity of the symptoms. Laboratory testing is used to identify underlying metabolic issues or hormonal deficiencies. Accurate endocrine assessment requires a serum total testosterone draw specifically in the morning, as levels naturally fluctuate throughout the day. If a clinician suspects severe vascular failure, they may utilize specialized hemodynamic testing. A penile duplex ultrasound evaluates the blood flow within the pelvic floor in real time. Peak systolic velocity measures the strength of arterial inflow during the cardiac cycle. By analyzing these velocities, urologists can differentiate between an arterial blockage and a failure of the veno-occlusive mechanism. This diagnostic rigor ensures that clinicians identify the specific broken node in the patient's physiology before initiating treatment. Management is governed by shared decision-making, where the physician and patient balance the efficacy of a treatment against its invasiveness. The first tier involves lifestyle modifications to correct metabolic issues like obesity and hypertension. First-line pharmacological treatments are oral PDE5 inhibitors. These molecules induce smooth muscle relaxation, allowing the arterial pathways to dilate. These medications rely on an intact neurological signal to function and may require concurrent testosterone therapy to reach full effectiveness. If oral medications are insufficient, the pathway moves to second-tier localized interventions. A vacuum erection device uses a non-invasive mechanical approach to draw blood into the tissue. Intracavernosal injections bypass the nervous system, delivering chemical vasodilators directly into the cylinders. This requires an in-office test to safely titrate the dosage and educate the patient on the risk of priapism or prolonged erection. For patients unresponsive to medical management, the final tier is surgical. A penile prosthesis implantation replaces the failed biological mechanism with a reliable, inflatable fluid system. The AUA cautions against unproven therapies, often marketed by predatory clinics. Low-intensity shockwave, stem cell, and platelet-rich plasma treatments are currently considered investigational. This escalating scale of interventions is designed to identify and implement the specific mechanical, chemical, or surgical bypass needed for each patient. Managing this condition addresses the patient's overall health alongside localized sexual function. Pelvic hemodynamics are deeply connected to the body's central cardiovascular engine. Localized hemodynamic failure provides a diagnostic window into the patient's future cardiac health. Moving past the social stigma of the condition allows for the diagnostic rigor required to identify these systemic risks. Adhering to evidence-based therapeutic pathways ensures that function is restored safely and effectively. This also includes the involvement of mental health professionals to address the psychological burdens and performance anxieties associated with the condition. Successfully managing the condition allows clinicians to identify, treat, and prevent systemic vascular collapse while restoring a patient's quality of life.